the objectives. We'll go through tests in bacteriology, mycology, and virology. Selected tests that are commonly requested. For bacteriology, we start with the gram stain, we proceed with the identification of the organism and antimicrobial susceptibility testing. We will also be discussing acid-fast bacilli, AFB. For the gram stain, it's the most fundamental test used in bacterial identification. It can separate almost all, so hindi lahat, almost all medically important bacterial organisms into gram-positive and gram-negative. So gram-positive are those that are seen as smears with deep blue color, and gram-negative organisms are those with pink to red color. Just a review of the cell wall of bacterial organisms. This is a cell wall of a gram-positive organism. This is the cell membrane. This is the membrane, and you have here a very thick mycolic acid, a very thick teichoic peptidoglycan composed of extensive teichoic acid cross-linkages. This is a gram-negative. This is the membrane. And you have here another membrane, the outer membrane. In between, you have the periplasmic space, and it contains a very thin peptidoglycan layer. So the gram-positive organism, because they have thick peptidoglycan layer, they retain the primary stain in the gram staining. This is the procedure in gram staining, that we fix the material on the slide with either methanol, or we can do heat fixation. If heat is used as in fixation, we allow it to cool to touch before we proceed with the staining. In the staining, we flood the slide, the smears, with the primary stain, the crystal violet, and we allow it to remain on the surface without drying for 10 to 30 seconds. Then we rinse with tap water. We have to remove the excess stain on the smear. Then we flood it with the mordant. So after the primary stain, this should be the color. Then we add the mordant, the grams iodine. It serves as the mordant. It increases the affinity with the crystal violet. And we allow it to remain on the surface without drying for twice as long as the crystal violet. So if the crystal violet was on the smear for 30 seconds, the mordant, the grams iodine, should be on the smear for 1 minute. Then we rinse with tap water to remove the excess mordant. So the smear, the material on the smear, on the slide, should be this color. Then we add the decolorizer for 10 seconds, and then we rinse with tap water. If it's still dark blue, we can repeat the decolorization. And after the decolorization, we flood the slide with counterstain. Before we do that, remember that the gram-positive organisms, they will retain the primary stain. That's the crystal violet. And so they should remain purple, blue. The gram-negative organisms, they have been decolorized, so they should be colorless. Then with the use of counterstain, we will flood the smear with a counterstain. The counterstain here is safranin. We allow to remain on the surface without drying for about 30 seconds. Then we rinse with tap water. This is what we should see. Gram-positive organisms, deep blue or purple. Gram-negative organisms here, pink to red. In gram staining, in our report, we include the gram reaction and the morphology of the organisms, including the arrangement. So here, what we should mention in the report is the presence of gram-positive cocci in clusters here, and the gram-negative bacilli. There are certain uh, gram stain specimen that will require us to include the location of the organism, just like in urethral discharge for males. If the consideration of the clinician is gonococcal urethritis, for the clinician to say that there is a true infection, we must include in the report that the organisms are seen intracellularly. So here you have gram-negative cocci in pairs. Commonly, we say diplococci. So gram-negative diplococci in pairs intracellularly located. Because if they are located outside the cell, these pus cells, it's not a true infection. This table shows you the scoring system for bacterial vaginosis for cervicovaginal discharge specimen. For us to say if the patient has bacterial vaginosis, the normal flora of in the genital tract is lactobacilli. And so kung sila yung madami, then there is no bacterial vaginosis. If there is less lactobacilli with proliferation of gram variable cocobacilli, which are Gardnerella vaginalis, then there is bacterial vaginosis. So there is a scoring, this is a scoring system. The score is based on the number of organisms per oil immersion field. The more lactobacilli in the smear, the lower is the score. Kasi normal sila, normal. Because the score is from 0 to 10. Yung final score is from 0 to 10. You will add up all these. The final score can be from 0 to 10. The higher the score is, may bacterial vaginosis for the final interpretation. So in scoring for the presence of lactobacilli, the more lactobacilli in the smear, the lower is the score. For Gardnerella vaginalis, the more gram variable cocobacilli in the smear, the higher will be the score. The higher will be the score. And so for the final score, if it's 0, 1, 2, and 3, it's a normal. There is no bacterial vaginosis. If the score is 7, 8, 9, and 10, we can include in the report, so long as it's validated by a pathologist, we can include in the report the diagnosis bacterial vaginosis. If the result is 4, 5, and 6, it's an intermediate or borderline. We can recommend repeating the test later, or if there are cells like this, we call them clue cells. This is a superficial cell coated by Gardnerella vaginalis. If these cells are present, we can say that it's consistent with bacterial vaginosis and no need to repeat the test later. For the identification of the organism, we can employ molecular techniques. For the genotypic identification, for the phenotypic identification, we start with the microscopic morphology and the staining characteristics of the organism. This can be derived by doing the gram stain. Then the macroscopic morphology. So we will culture the organism, we will allow them to grow on culture media, and we will observe for their colonies, the macroscopic morphology of the colonies. To identify the organism, to come up with the genus and the species, we exploit, aside from looking at the morphology, microscopic and macroscopic, we exploit the environmental requirements for growth of the organism, the resistance or susceptibility pattern of the organism to certain antimicrobial agent, and also the nutritional requirement and metabolic capabilities of the organism. So, for example, ang nakita natin sa smear ay gram-positive cocci. Gram-positive cocci. So with that, ang iisipin natin ay could be a staphylococcus or a streptococcus. And for us to say na siya ay staph rather than strep, we will be using catalase test. I-exploit natin yung presence of catalase in staphylococcus, in staphylococci. So with staph, the test will be positive. Kapag negative, could either be a strep or enterococci. We can culture various specimens from the body. Common specimens that are received in the laboratory are sputum, blood, and the urine. Because a cultural result will take days to be generated, an empiric therapy is started. Empiric therapy because they give antimicrobial agent, and the choice is basically based on the most likely organism that is infecting the patient based on the clinical findings by the clinician. It's usually a broad spectrum antimicrobial, and when we release the culture and sensitivity, so in the sensitivity, included in the report are the antimicrobial agents that can be used by the clinician. The clinician will shift the antimicrobial agent to the agent that is in the report, agent na kung saan susceptible yung organism. For sputum culture, this is usually requested for lower respiratory tract infections like pneumonia. For a gram stain, we will do first a gram stain, and for us to proceed with the culture, we will assess if it's really sputum or saliva. Sputum is if it is sputum if the squamous epithelial cells are less than 25 per low power field on the average, and ideally with at least 25 pus cells. If there are more than 25 epithelial cells per low power field, the specimen is likely saliva, and we will release a report that the specimen is unfit for culture, and we are recommending for recollection. So we will not proceed with the culture. We will wait for the new specimen. For the urine culture, the volume of the specimen should be at least 10 ml. 10 ml. The definitive method for collecting uncontaminated specimen is by doing suprapubic aspiration. Suprapubic aspiration. The commonly submitted specimen, however, is voided midstream catch, collected through midstream catch. A catheterized specimen can also be used, but we have to discard the initial flow because it is likely contaminated. In gram staining of urine, if there is at least one bacterial cell per oil immersion field in at least 5 fields, looking at an uncentrifuged urine, then there is at least 10 to the fifth colony forming units. Colony, it is important yung colony kasi we count the colony in urine culture. We report the colony count. And so the volume that is inoculated on the culture medium should be standardized. And it is done by using a calibrated loop, 0.01 ml calibrated loop, and we incubate it for 24 hours, the culture media with the inoculum. If the colony count is less than 10 to the second power, CFU per ml, or there is no growth. And if the patient has no pyuria, there is no increase in pus cells in the urine with no symptom, likely there is no bacterial disease. But if the patient is symptomatic, presenting with the usual signs and symptoms of UTI, it can be that the organism is chlamydia or viral organisms like CMV or adenovirus. If there is pyuria with no symptom, it's aseptic pyuria. If there is symptom, it's urethral syndrome. If the colony count is at least 10 to the second power to 10 to the fifth with no pyuria and no symptom, it's likely a case of perineal colonization. If the patient is symptomatic, it could be non-infectious in nature, or if it's infectious, it can be a case of chlamydial infection. If there is pyuria with no symptom, it's asymptomatic bacteriuria. If the patient is symptomatic, then it's asymptomatic bacteriuria. If the colony count is at least 10 to the fifth per ml, with or without pyuria, with no symptom, then it's a case of asymptomatic bacteriuria. If the patient is symptomatic, it could be a case of cystitis or pyelonephritis. Next, blood culture. The best time to collect blood for culture is when the patient is febrile or before the fever. Commonly, you will receive a request for collection of sample from multiple sites, at least 2 sites. It can be collected simultaneously or consecutively. Consecutively, such as in patients with infective endocarditis, and the typical interval is 30 to 60 minutes. The volume is very important for blood culture because it improves the sensitivity of the culture. Comparing it with the number of sites in increasing the sensitivity of the culture, volume increases the sensitivity more than what the number of sites can contribute. The minimum volume per bottle should be 10 ml. However, we can be flexible for newborn and children. For newborn, especially those less than 1 kilogram in weight, at least 2 ml. For those up to 2 kilogram, at least 4 ml. For child up to 12.7 kilogram, at least 6 ml. And for those up to 36.3 kilogram, at least 10 ml. For adults and those who weigh more than 36.3 kilogram, the desired volume is at least 20 ml to 30 ml. Then we incubate the bottle. We will incubate the bottle, and when there is growth, we will be flagged. Tutunog yung machine, kukunin natin yung bottle, and then we will be doing a gram stain. A gram stain. Gram stain of the blood is not routinely done before the culture. Before the culture, it is not done. If there really is a need for it, we will make use of the buffy coat for the culture for the gram stain before the culture. But it's not routinely done. It's not routinely done because it can promote contamination of the sample. So we do it after the culture. If there is growth, so na flag, there is growth, there are organisms in the bottle, we will do gram stain, aalamin natin kung ano yung organism, likely na organism na present based on the gram reaction and the morphology. And we will release a preliminary report stating the gram reaction and the morphology of the organism. So here, kung merong gram-positive cocci sa 20th hour na incubation, we will say positive for growth of gram-positive cocci after 20 hours of incubation. Then we will proceed with the workup to identify the organism. So these are examples of the battle, the BACTEC battle. If the clinician has already started the patient on antimicrobial agent, we can still proceed with the culture, but we will make use of bottles with ARD, antimicrobial removal device. These bottles are with resins that can absorb antimicrobial agents, thereby allowing the organisms to grow. Antimicrobial susceptibility testing. We usually use the modified Kirby-Bauer disk diffusion method. This is a routine technique to test the sensitivity of the isolate, the organism, to antimicrobials in the clinical laboratory. This is how we do it. We prepare the inoculum from primary culture plate, so the media, by attaching with a loop the tops of each of 3 to 5 colonies on the culture media. Then we transfer the growth to a tube of saline. The saline will therefore be turbid. It will be turbid. This saline with the organism eventually will be inoculated on a plate. And for the growth to be not too thick or not too thin, we have to compare the saline with the organism with a 0.5 McFarland turbidity standard. So that we will have just the right amount of organism suspended in the saline. So this is a McFarland solution. Then this is how we inoculate the organism, and to make sure that the entire plate will have the saline with the organism, we will rotate it by 60 angle and 3 times. Then we will leave the inoculum to dry for a few minutes, at least 3 to 5 minutes. Then we will then place the antimicrobial impregnated discs, the discs with the antibiotic, antimicrobial. The disc should not be placed closer than 24 millimeter because there will be several discs on the plate. After that, we will incubate at 35 degrees within 30 minutes dapat malagay natin siya sa incubator, and the results can be read after 18 hours. We can measure using a ruler or a pair of caliper. So ito yon. These are the discs impregnated with antimicrobial agent. Then there is a zone of inhibition, area na walang bacterial growth around the disc. Around the disc. Kaya merong distance na 24 millimeter between each disc kasi nagkakaroon ng zone of inhibition. So paano siya ini-interpret? Using the CLSI guidelines, we determine the susceptibility or resistance of the organism to each drug tested. So there are different charts for different organism. Magkakaiba sila ng breakpoint. So for each drug, we have to indicate on the recording sheet whether the zone size is equivalent to a result of susceptible, intermediate, or resistant. So there is a chart for each organism. There is a chart for each organism. If done precisely, the disk diffusion method can give us a reliable result. It can reliably predict the effectiveness, in vivo effectiveness of the drug in question. However, there are also limitations that it cannot provide accurate information about the minimum inhibitory concentration, the lowest concentration of the antimicrobial agent that can inhibit the growth of the organism. It cannot be provided by the disk diffusion method. It does not provide also reliable results in certain antibiotic organism combinations, such as in penicillin G for Neisseria meningitidis and Streptococcus pneumoniae. This test can provide the MIC, the minimum inhibitory concentration. This is an epsilometer test. It provides a means for producing MIC data in those situations in which the level of resistance can be or is clinically important. Kung saan nag-i-intersect dito, that's the MIC. So here it's 0.25, so the MIC is 0.25 microgram per ml. That's the minimum inhibitory concentration. So ito yung interpretation ng bawat result. Susceptible, intermediate, resistant. If the zone of inhibition upon measuring is equivalent to a susceptible result, that means that the antimicrobial agent in question may be an appropriate choice for treating the infection caused by the bacterial isolate. If the result is resistant, the zone of inhibition is equivalent to resistant. So may zone of inhibition pa rin, pero based on their observation, hindi clinically effective. So ang classification yan is resistant. So it may not be the appropriate choice for treating the infection caused by the bacterial isolate. Merong result in between resistant and susceptible, intermediate. So it can be, the category is used to indicate a number of possibilities. It can be used, it can possibly be used as an antimicrobial agent in body sites where they can be concentrated, like in the urinary tract. So that will depend on the drug. The antimicrobial agent may still be effective against the tested isolate, pero less effective than those with susceptible result. Next is AFB, a test that is specifically designed for a subset of bacteria whose cell walls contain mycolic acids. These mycolic acids render the cells resistant to decolorization. Hindi lang Mycobacterium tuberculosis ang AFB positive. Other organisms like Nocardia and Cryptosporidium are also acid-fast organisms. So this is how we do um, AFB using the Zeal-Nielsen or the classic method. So we fix the smear. After the fixation, we flood the smear with carbylfusin, that is the primary stain, and we heat to almost boiling by passing the flame of a Bunsen burner underneath the slides on the metal rack. We allow the stain on the slide to produce steam, and after that we allow the slide to sit for 5 minutes, pero hindi dapat matuyo yung stain. Then we wash the slides with distilled water. We drain off the excess fluid. So with carbylfusin, red yan, so dapat red yung mag-appear yung smear. Then after that, we will flood the smear with 3% HCl in 95% ethanol. This is acid alcohol, a decolorizer. And this is done for about a minute, 1 minute. So the organism, those that are acid fast will resist the decolorization, and so they will remain red. Those that are not acid fast can be decolorized, and so they will become colorless. After the decolorization, we will flood the smear with methylene blue, a counter stain. We will allow it to remain on the surface of the slide for a minute. Then we will wash it with distilled water. Tapos blot drying. The organism for the acid-fast organism will remain red, while the non-acid-fast organism will stain blue. They will take up methylene blue. However, if you look at the smear, acid-fast bacilli man ang nandyan or non-acid-fast, will appear blue. The smear will appear blue. Pero if you look at the smear under the microscope, this is what you'll see. If there are acid-fast bacilli, you will see these rods, bacilli, na na-retain ng carbylfusin, so red. Kasi they resisted the decolorization kasi they are acid-fast. So how do we interpret? How do we release the result? If those organisms there are not present, so no acid-fast bacilli, the reading is zero. It's zero. If there are organisms, if there are acid-fast bacilli, we are only required to look at 100 fields. But if there are no organisms, acid-fast bacilli organisms in 100 fields, we are required to go through 300 oil immersion fields before we declare that the reading is zero or negative or no AFB. If there are only 1, 2, up to 9 AFB per 100 fields, we will release it as plus n, and n here stands for the number of the organism. So if there are only 5, so it will be plus 5. The higher the number, succeeding number, mas maraming organism na present. So babalik rin natin, number muna 1 plus, if there are 10 to 99, AFB per 100 fields, 2 plus if there are 1 to 10 AFB per field in at least 50 fields, and 3 plus if there are more than 10 AFB per oil immersion field in at least 20 fields. Dati, 3 samples yung kinakailangan na i-test, pero recently, na-revise siya. Only 2 samples are required for the testing. Kung nag-collect ka ng first sample today, the second sample should be submitted tomorrow. Kung talagang walang choice, talagang kinakailangan ngayon pareho yung result, the minimum interval for the collection is at least 1 hour. So yung first collection mo, 12 noon, second collection mo is 1 o'clock, that it's still valid. If the second sample cannot be submitted within 3 days, repeat testing. Magre-repeat unless the first sample is already positive. Unless the first sample is already positive. Tests in mycology. So KOH. KOH is potassium hydroxide. It is the reagent, it's also the name of the test, and it's usually used in as a 10% solution, 10% KOH. The usual samples are skin scrapings. Rarely, nakakatanggap rin tayo ng nail clippings. Nail clippings. The purpose of the reagent, potassium hydroxide, is to clear the specimen of the debris, like keratinaceous debris. And after that clearing, we'll be left with the epithelial cells and the fungal organisms, the hyphae and the spores, the yeasts. So typically, makakatanggap tayo ng skin scraping na nakalagay sa glass slide. Magkapatong yan. Tatanggalin natin yung cover na glass slide. Then, pag nakita natin yung skin scraping, papatakan natin ng KOH. Then, lalagyan natin ng cover slip and we'll allow it to stand for 5 minutes. 5 minutes. Then, we will look at it under the microscope on HPO. If kulang pa yung clearing, pwedeng patagalin pa yung incubation sa room temperature lang from 5 minutes to 10 minutes if clearing is not complete. If for nail clippings na medyo matagal, we can actually increase the concentration of KOH from 10% to 20%. So ito yan, example. This is an actual case. You have here the hyphal elements. These are the hyphal elements. So ang report natin, positive for fungal organism or fungal elements. Then we specify kung ano yung nakita natin, yeast cell or hyphae. Next is germ tube test, which is the most generally accepted and economical method used in the identification of yeasts. This is used to differentiate Candida albicans versus or from Candida tropicalis or yung isa pang organism na previously Candida rin ang tawag pero ngayon Turolopsis. Turolopsis glabrata. Dati tinatawag siyang Candida glabrata. So what we do here is we get an aliquot of serum, 0.5 ml. That's about 12 drops. Or the media in a test tube. We make a light suspension of the suspected yeast colonies sa serum. We incubate the tube for 2 to 4 hours in 35 to 37 degrees in temperature. Then kukuha tayo from the suspension and we place a drop of the suspension, that suspension on a slide using a pasture pipette, and we cover it with, syempre, cover slip. Then we examine the wet mount microscopically at 40x. And we will look for germ tube. Germ tube. So, yeast cells. Yeast cells yan. Dito, merong filamentous extension. Ito. Ito, pseudohyphae daw. This is a true hypha. Paano natin malalaman na true hyphae yan? True hyphae or germ tube. If there is no constriction here, it is a true hypha. If there is a constriction here, it's not a true hypha. It's just a pseudo hypha. So if this is what you'll see, then it's not Candida albicans. This one is Candida albicans. Next, India ink. For India ink, this is the most widely used method for the rapid detection of Cryptococcus neoformans in clinical specimens. Typically, we receive CSF for India ink preparation, CSF. This can delineate the large capsule of the organism, Cryptococcus neoformans, because the ink particles, the India ink, cannot penetrate the capsular polysaccharide material of the organism. Nahaharangan niya, and so nadidelineate niya. The color can range from as light as this, medyo brown, to talagang black. So ito ang capsule. This is the organism. So ang nasa stain yung background, not the organism. So this is a background staining or negative staining. Negative staining. And typically, if this is requested for, sabihin nating CSF, meron siyang isang test na kasabay lagi. Cryptococcal latex agglutination test, or tinatawag rin siya ng iba na CALAS, which is a serologic test for Cryptococcus neoformans, detecting the antigens of the organism. So latex agglutination test. For virologic tests, chunk smear. So ito ay nire-request if for patients with cutaneous vesicles suspected of having infection with herpes simplex virus or varicella zoster virus. Those vesicles, they typically rupture, at pag nag-rupture yan, na-expose yung ilalim niya, yung base, which is slightly depressed, kaya parang ulcerated. So kumukuha tayo ng specimen from the base of the ulcer. So impression smear, dinidikit, or pwede rin namang kukuha ng cotton pledget, then ita-transfer dun sa glass slide. Then the smear is sent to the laboratory for staining, looking for this. We will be looking for this. The pathologist will be looking for this. So this is a cytopathic effect, secondary to the presence of the organism, VZV or HSV. So if this cell is seen, we will release a report na positive for viral cytopathic effect. Pag wala, edi negative for viral cytopathic effect. Next, SARS-CoV-2. This is the last topic. Dinagdag ko lang siya recently para ma-update. This is the agent, as we know, of COVID-19. And as per Department Circular 2020-143 of the Department of Health, issued on March 19, 2020, this is the recommended testing kit. Testing kit for COVID-19 is RT-PCR. And just a review, alam naman natin ang RT-PCR has three main steps. Yung conventional, denaturation, annealing, and extension. That in denaturation, there is unwinding of the strands using heat. And then there is annealing, which is attachment of the primer to the target segment. This is done in a much cooler temperature. So the primer will attach to the target segment, and then there will be addition of nucleotides to the primer. Pahahabain natin siya. That step is known as extension. It is noteworthy to mention that before we proceed with the amplification, this is an amplification technology. Diba? Amplification technology to. We first produce complementary DNA. So remember, COVID is the organism here, the SARS-CoV-2 is an RNA virus. We first produce a complementary DNA. So again, the recommended testing kit is RT-PCR. RT-PCR, it's real, ang gusto natin is, ang desired natin is real-time reverse transcriptase PCR. So real-time RT-PCR. Yung RT sa PCR, hindi siya real-time. It's reverse transcriptase. Reverse transcriptase. Para sabihin natin na real-time, ang dinaragdag natin is Q. So real-time PCR is qPCR. Real-time RT-PCR is QRT-PCR. QRT-PCR. So the specimen, primarily upper respiratory specimen, nasopharyngeal swab or oropharyngeal swab. Nasopharyngeal swab or oropharyngeal swab. Uh, for more severe diseases, we can collect or we can accept lower respiratory specimen like sputum, bronchoalveolar lavage, and endotracheal aspirate specimen. So this is again the recommended test for SARS-CoV-2. SARS-CoV-2.